Hello friends, today we'll be discussing two important causes of chloride unresponsive hypokalemic metabolic alkalosis. The two causes are Bartter syndrome and Gitelman syndrome. Now these two syndromes share a variety of common features such as a low potassium, metabolic alkalosis. The BP is usually normal to slightly low. Both these patients have tertiary hyperaldosteronism, which is due to the sodium loss in urine, and this manifests as an increase in plasma renin and aldosterone levels. Both these patients also have low levels of magnesium in their serum. Magnesium levels, however, are markedly low in Gitelman, which is an important differentiating point between Bartter's and Gitelman's. Now, about the pathogenesis, Bartter syndrome occurs due to the mutation of sodium potassium chloride cotransporter present in the thick ascending limb of loop of Henle. Due to the impairment, there is increased loss of sodium, potassium and chloride in urine, as well as an impaired reabsorption of calcium. This causes increased loss of calcium in the urine, leading to hypercalciuria. In Gitelman, there is an impairment of sodium chloride cotransporter present in the distal convoluted tubule, and a contrasting point with Bartter's, this sodium chloride cotransporter impairment actually leads to increased reabsorption of calcium, thereby presenting as hypocalciuria. This brings us to another important differentiating feature between these two syndromes. Bartter syndrome patients present with nephrocalcinosis. They have renal stones, whereas Gitelman syndrome does not have nephrocalcinosis, and this is because there is low calcium in their urine, and there is high calcium in the urine of patients of Bartter's, and therefore renal stones are seen. Bartter syndrome patients, when we do a renal biopsy, we see a hyperplasia of juxtaglomerular cells, and these cells produce a lot of prostaglandins, and therefore an important point is that in treatment of patients of Bartter's we use indomethacin to curb the high levels of prostaglandins secreted. Bartter syndrome, broadly speaking, we can differentiate into a neonatal Bartter's, which is type 1 and 2 Bartter's. These patients usually present in utero as polyhydramnios, high levels of amniotic fluid, or in an early neonatal stage as fever, dehydration, and an early onset nephrocalcinosis. Early renal stones are seen in these patients. The second type is the classical Bartter's, also known as type 3 Bartter's. These patients present in the infantile stage as polyuria and growth retardation. There is growth retardation in these patients. Important point to note here is that nephrocalcinosis is not a feature in classical Bartter's. It's an important point that should be noted here. Another important thing, that type 4 Bartter's is the type that is linked with sensory neural hearing loss. It's an important question that is asked. It occurs due to the mutation of Bartter gene at chromosome 1p, and it has sensory neural hearing loss. Patients of Gitelman are usually older children, and of course every finding is milder in Gitelman compared to Barter's. The two important points, I'll write up them again here, that the serum magnesium levels in Gitelman are severely low, and second is that these patients will never have nephrocalcinosis. These patients do not have renal stones. This broadly sums up all the important points between these two syndromes. I hope you like this video. Thanks a lot.